main speaker, Dr. Saag. This reminds me of what a remarkable membership we have. Dr. Saag is a fellow Rotarian, a physician at UAB's Division of Infectious Disease who has participated in efforts to educate the public about the COVID-19. He's also tested positive for the disease, and that announcement was made by fellow Rotarian UAB President Ray Watts, who addressed the UAB community and the community at large. Ray said that Mike wanted his case to be an example of the COVID-19 reality and the importance of practicing aggressive social distancing. And it is simply our good fortune that he hopes to protect all of us by sharing his insights today. Dr. Saag is a physician scientist and an activist. He currently serves as the director of the University of Alabama at Birmingham Center for AIDS Research. And during his fellowship in infectious diseases, Mike conceived the concept of a comprehensive HIV outpatient clinic dedicated to the provision of comprehensive patient care. And over the last 25 years, the clinic has treated more than 9,000 patients and has become recognized as one of the best sites for clinical research and care in the US. He's published over 300 articles in peer-reviewed journals. He's appeared on, featured on National Public Radio, and was listed as one of the top 10 cited HIV researchers by Science Magazine. He has a host of honors and awards, including the 2010 President's Medal at UAB, the highest honor given at that institution. And in 2014, Mike received the Castle Connolly National Physician of the Year Award for Clinical Excellence. So with that, please welcome Dr. Mike Saag. And Mike, thank you again for joining us today and passing on your message. So Mike.
Thank you, President Philippe. Thank you, everybody. Historic for sure. Not only is this a meeting for the first time virtually on Zoom, but it's also perhaps the first time that someone is talking to you about an infectious disease that they actually treat and they happen to have. So I'm going to give you insight that goes into the COVID-19 story, but also tells us about what it's like to the person who's dealing with it. So I'll give you just a bit of background and then we'll go to the slide set. I'd like to leave a good amount of time for questions, so I'm just going to hit some high points along the way. But the concept of this pandemic is something we've never seen before in our lifetime. Perhaps our parents or grandparents lived through the 1918 flu epidemic, but we've never seen anything like this, and it's unprecedented. And when people say, well, why are we getting so exercised about it? It's because it is so new and it is expanding in very dramatic ways, and it's challenging all of us to do the right thing. I'm going to go beyond a little bit of the data, but talk a little bit of how those data convert to policy. And with that, Sarah, if I could bring up the first, please. There we go. Perfect. So let's go to the next slide, please. All right, so what is a coronavirus? No, it's not named after a beer. It means that it has an outer layer that looks like the sun. And as you see from the structure over here, this is the virus. It's an RNA virus. It's the most common, one of the more common causes of the cold, the everyday common cold. So we've experienced a lot of coronaviruses in our lifetime, and there's tens of thousands of them, both in the human and the animal community. It likes to replicate at lower temperatures, and therefore it has a predilection for the respiratory tract, especially the upper tract. And as you know from the common cold, it's difficult to control transmission. Next slide. Now, the first time we ever heard of an aggressive type of coronavirus was with the severe acute respiratory syndrome virus from 2002. Let's take a little bit of a time out. What this is a zoonotic infection, the one then and the one now, meaning there's a lot of coronaviruses in the animal kingdom, especially bats are an important reservoir. Sometimes the bats themselves could transmit to humans, but more commonly, the bat uses an intermediate host. In the case of this, it was the civet cat. I'll show you a picture in a minute. But they could go to the civet cats could be sold in a market, and if the cat was infected, then the secretions from the cat get into the environment, and then ultimately through mutation, the virus becomes infectious for humans. The important part of this is, since this virus, that is the SARS-1 back in 2002, as well as today's SARS-2 virus, the key point is that we've not, as a human race, as a group of people, ever experienced this particular infection before. Therefore, none of us have immunity. So once we get infected, we are going to, for sure, have an immune reaction to it that's new, that's not a reaction from a recollection of what our immune system has seen before. This is all new, which is why it's so prevalent and why the disease, in the case of the current SARS epidemic, is affecting so many people. The important part that we learned from the last SARS epidemic is that there can be super spreaders. There are people who can spread up to the virus to up to 80 people. And in this case, there was a physician who went to Hong Kong, and a lot of people got infected at that point in time. And by the time April came around, 29 countries had been involved. Next. Yeah, that's the civet cat right there. Next, thanks. This is the original SARS, well, I'll call it SARS-1. You can see that it went all over the world. Interestingly, we look at the numbers, and 774 deaths. Well, we've had about that many in the United States now, and 8,000 total cases. That's fewer than we have even in the United States. And so this was a blip on the radar, but it never really took hold like this current SARS did. And it got people in public health thinking about how vulnerable are we to the next pandemic. This started back in 2003, and people started getting worried about different strains of flu, and could that take over? And so there was preparedness that was done, but to be honest, it was fits and starts. There were certain administrations, for example, in the government, who really embraced this, went after it, and then others who thought, well, we're not really threatened by this, so we're not going to pay as much attention. And so that fits and starts kind of policy has ultimately left us a little bit unprepared for what we're experiencing right now. In the ideal world, we would have had an entire response team ready to go and would have jumped on it. But we just didn't have that totally online at the time that this hit. Next slide. The other, go ahead, next slide, please. Yeah. The other concept that is very, very important is that for the original SARS and for this one as well, the biggest concern is the healthcare workers. The healthcare workers made up almost 50% of the cases of the original SARS epidemic, and ultimately 40% or so of the total ones that were affected. So it's a very scary thing for folks taking care of patients, of what it's like to manage and such a large number. And I'll give you an update from UAB as we get towards the end. Next. So we also had another SARS coronavirus called MERS, Middle Eastern Respiratory Syndrome. It was originally out of Saudi Arabia, did not affect nearly as many people. It had a fairly high fatality ratio, a lot of deaths, over 800, but only about 2,500 total cases. And so we knew about this, but it never really reached pandemic proportions. And what pandemic means is an explosion of cases in multiple geographic areas, especially on multiple continents at one time, which is clearly the criteria that we've met with the current SARS-2 epidemic. Next slide. The original idea was that this might have come from camels. For those of you who remember Aladdin, careful, they spit. But this is probably came originally from bats. And they couldn't ever document it back to the camels, although it's believed that it might have started there. But again, this is the whole concept of a virus that's indigenous in an animal species, and then it mutates in such a way that it can become infectious for humans. And that's what we're dealing with here with the SARS-2. Next slide. So here we go. This is SARS-2. The first thing that people want to know is, how infectious is it? There's an infectious disease concept called R0, which means the number of people that the single sick person can infect on average. And you can see on the far right-hand side that measles is one of our most infectious disease. It doesn't take many cases. Mumps is another one. SARS has got about a contagious rate of about 4, which is really pretty high. Influenza is more like along the 1 or 1.2 range. So this is much more infectious than your average flu. And I can tell you just anecdotally in my case, I was doing all the things that we were told to do, washing my hands, trying not to touch my face, wiping down surfaces. And I'm telling you that despite all that, I still became infected. So that's where the beginning of the concept of this shelter at home idea has come from. And I'll give you some data that supports that policy as we go through. But this is a very infectious virus. Next slide. Now I'm going to spend a little time on this slide because this is these are some x-rays. You don't have to be a physician to see that there's a lot of disease in the lungs. You should normally just see the lungs should be black when x-rays go through the air in the lung, and when it gets blocked, the x-ray, then it shows up as white. And you can see that this is bilateral, meaning both sides have pneumonia. So let me pause for a minute and tell you about my personal case and what this has been like on a very, very personal level. So my son and I drove back from New York on a week ago Thursday, and he wanted to come to Birmingham for a little while, so we put his dog in the car and we drove back. About midway through the trip, he started feeling a little ill. By the time we got to Birmingham on that Friday night, he started having a chill and a fever, and we kind of looked at each other and said, okay, looks like you got this. So he went into quarantine, I went into quarantine. By Saturday afternoon, I started getting some symptoms. Initially, the symptoms are very mild. This is very, very different than influenza, which those of you who had the flu know what I'm talking about. You get, boom, you get hit with this all at once, and within an hour, you're just low sick and cough and fever, just feel terrible. This was nothing like that. I had a little cough, headache, some muscle aches, not much. Just kind of felt tired. The best description I can have, and I don't have a medical term, called fuzzy headedness. I just couldn't think straight. If I was looking at email, I got fatigued pretty quickly. And I thought, okay, well, I can live with this. This isn't so bad. And we both got tested on Monday a week ago, and we both tested positive. I said, okay, all right. By Tuesday, Wednesday, he was turning the corner and was well. And by Wednesday last week, I thought I was through with it. I felt better. I was able to get stuff done. And then unfortunately on Wednesday night, boom, I just had a terrible evening and had fever and couldn't get comfortable, couldn't sleep well. And this is all from the so-called release of cytokines. Cytokines are chemicals that are produced by our body to fight off infection. They stimulate the immune system. And it's the cytokines, really, when you think about it, that create most of the symptoms of an infection. That body aches, the fever, that all comes from our immune system sending out chemical signals to other cells saying, hey, wake up and start working here. But when the cytokines get released in excess amount, it can really cause damage. And in this case, it can cause pneumonia and can make people really sick in a hurry. I've been through that now for 6 or 7 nights in a row, and the night before yesterday, I felt like I was turning the corner, but then again last night, boom, I had another bad night, and just felt horrible. And the scary part is, for anyone who has this, is that you never quite know if that feeling horrible is going to go into the stage of respiratory distress where you can't breathe well. Fortunately for me, that hasn't happened, but for a lot of people, it does happen. The sad part is we can't predict who's going to get in trouble with it and who's not. I can tell you from firsthand experience, none of us, no one wants to get this. I don't care of your age. I don't care what your underlying health condition is. This is a bear, and it doesn't want to let go. So I've been talking to experts around the country, in fact, around the world. They've been telling me that I can just tough it out another day or two and it should turn the corner. I'm hoping that's correct. I believe it's correct. I think I'm through the worst stages where I could progress to the pneumonia stage. I don't think that's going to happen, but it's harrowing because there's a lot of people who get admitted to the hospital, and once they get admitted, they can deteriorate very quickly and end up on a ventilator. So this is very real and very scary, and so it's something we all want to avoid at all costs. Before I go a little further, let me give you an update on UAB, and I'm sure other hospitals in the city are similar. A week ago, we had very few cases. We had a couple of what's called persons under investigation, but very few cases. Just yesterday, we were up to 56 total cases in the hospital, consuming about 2.5 units of, on our wings of our hospital. 26 people are in the ICU, and that's in less than a week. So it's hitting us, all of us now, with a vengeance. And it's not going away in the next 2, 3, 4 weeks. It's only going to get worse. And so we have to be vigilant, and we have to do what we can do to prevent this infection from transmitting from person to person. And you've heard the data overall. The bottom line is that about 80% of the people with this sort of get through with mild to moderate symptoms. 20% end up going to the hospital. And when we start looking at the numbers in a minute, keep those percentages in mind when you start extrapolating what a large number of cases means to our health system, just locally in Alabama. It's going to be a real challenge for all of us, and we're going to have to be ready. A lot of people are doing a lot of work now, but I will tell you, obviously, I've been in the same room here since a week ago Thursday, so I'm not really out on the wards at all, of course. But I am hearing from my colleagues that the morale among the nursing staff is really being strained because it's just one case after another, and of course, this is just the beginning. So we've got to support each other, and we've got to support our staff, and make sure that we protect people from getting infected if they're on the front lines. So let's talk a little bit about the numbers and why this concept of social distancing and sheltering in place. What's the data behind it? So let's dig into that a little bit. Next slide. This is a little busy, but stay with me as I walk you through it. This is Wuhan, and you can see an area in China. The key thing to focus on are the blue bars and then the orange bars. The blue bars are the date and time of actual infection. The orange bars are when somebody showed up to be tested. And you'll notice there's about a 2+ week lag between when somebody got infected and when they showed up either sick or to be tested. About a 2-week lag. So you'll notice in the center of the slide on top, it says lockdown. That's when the Chinese government said, okay, we're putting the clamp on this. And we saw this starting to happen. I lost my screen. Are you also, oh, I'm there. Okay, never mind. Yeah, so we saw, so they saw this coming and they acted very quickly. But you'll notice that a lot of the people, by the time they hit the lockdown button, there were a lot of people already infected. And you'll notice that after they did lockdown, then the transmission started to drop, such that by the far right-hand side, by February 10th and 11th, there were very few new transmissions happening. But look at the number of cases. So the cases were still spiking from the transmissions that occurred in late January. So when we start thinking about dates and times that we're going to back off of whatever restrictions that we have, we've got to be smart about this. If they had locked down in January and then suddenly released it at some arbitrary time, let's say in mid-February, there could have been a recrudescence, and this thing could have come roaring back. We have a lot to learn from China because their experience has shown the way of when is it safe to re-release people back to their regular activities. We shouldn't just pick a date and say, okay, that's the date we're going to do that. That's not going to cut it. We've got to be scientific about this. And I know that Dr. Birx and Dr. Fauci are all over that. And these are the types of data that they're looking at when they talk to the president and when they talk to other policymakers in DC. Next slide. So China did a good job. You can see now we're looking on the timeline is mostly in February. Most of the Chinese provinces were able to keep their cases low because they started doing social distancing and sheltering at home very, very early. And look at South Korea, it spiked. But to their credit, once they saw the spike starting to happen, they did aggressive social distancing and aggressive stay at home and isolation. And they've since have brought this under control. Italy, on the other hand, was the opposite. Italy started to spike and it just overwhelmed their country. Those of you who've been know the country pretty well. I know it well from a medical standpoint. Northern Italy, near Milan, has some of the best health in their country. Their hospitals were overwhelmed by the 1st of March. And it was so pathetic because I was getting notes from colleagues who worked there who, number one, were exhausted, but number two, they had run out of ventilators. And they were having to make literally life and death decisions, scouring through the hospital, looking at who was already on a ventilator and saying, what's that person's chance of survival? And if it wasn't good, they pulled them off the ventilator and put somebody on who had a better chance of survival. I can't even begin to imagine what that's like. I don't want to know. But when desperate times happen, you've got to make a decision, because if you leave the person outside in the ER and you don't admit them because you don't have a bed, that could be someone who had a decent chance of survival, but not admitting them basically gives them a death sentence. So the concierge is something that you hear a lot of people in New York and others giving, sounding the alarm. They don't want to go there. None of us do. But I think that's what we'd like to avoid. One other thing, if you just put yourself now into the realm of possibility that this could happen in Birmingham. Let's say we get overwhelmed, and that could happen. If we get overwhelmed, and let's say all of our ICU beds are mostly full, citywide, and we do what we can to create makeshift ICUs and even operating rooms or wherever we can. The COVID cases, yeah, I get that. They're going to be backed up. But what about the average type of case that usually comes into the ICU because of a burn or trauma or a heart attack? There won't be a bed for that person. And so there's secondary and tertiary derivatives of this that is, if you start to think about it, you get it. But if you've never thought about it, you go, huh, okay, now I see what he's talking about. And that's why when you hear leadership in areas of the country that have embraced this notion of social distancing, is to prevent that type of catastrophe from happening. None of us want that to happen. certainly not in Birmingham, and certainly nowhere else in the community, in the world. Next slide. Thanks. All right, this is probably one of the most important slides that I'm going to show you. This shows you the number of days into an epidemic, and you can see it starting to grow exponentially. And if you started the social distancing on day 20, you can have some effect on the curve. If you waited a day later, you can see you also have effect, but you don't have nearly as good of an effect. Let's go to the next slide. If we blow that up, this is one of the more sobering slides I've ever seen about the epidemic. Waiting one day means that 40% new infection transmissions occur in that one day we waited before doing the right thing. One day, 40% new transmissions. So let's bring it down to Birmingham. I couldn't be prouder of our Jefferson County Health Department and the mayors and the communities throughout our region, especially Mayor Woodfin, but many others, who have aggressively understood this and translated this concept into policy. And a lot of people were pushing back. What do you mean I can't go to church on Sunday? What are you doing to me? This is a sacrifice I don't want to make. But this is the reason why. Because we see the epidemic hitting us. I just gave you the data from UAB. That's again, think about the transmissions, and when the cases show up, we're already behind the 8 ball. So it's going to be 2 weeks from whenever we started our social distancing to where we might see a plateauing in the number of cases showing up. More like 4 weeks that we'd actually see it perhaps start to turn down. This is why you hear the scientists beating their hands on the table saying, do not wait, do not wait. New York was a little bit late, and trust me, I know a lot of those people in New York at their health department. They're smart people. They just didn't anticipate it soon enough. And they since have done all the things you see, the Times Square show, you've never seen Times Square that empty. You see the way the city is now. But trust me, they are in a state of emergency in a way that I don't think any of us could have imagined. And they started just a little bit late. Birmingham, I think we started early enough. And again, through insightful leadership amongst our government officials and health department, I couldn't be prouder of their embracing of this, as well as other clergy leadership that I've spoken to. I think people get it, and I think it's made a big difference. Will continue to make a big difference. Next slide. So let's go back to this concept of what's called flattening the curve. You've probably heard that. This is graphically what it means. If you look at the dotted line, just the black dotted line, that's what happens if you don't do anything. And all the cases just show up at once. And you don't have to do a lot of quick math to see that overwhelms the system rapidly, like what happened in Italy. But if by acting early enough in the green sort of hump there, we defer some of the transmissions to a later time when the system is better ready to absorb it. So that's why the action of, especially in Birmingham and Jefferson County, that's why it's working out so far. And I'm hopeful that we've done enough soon enough to make a big difference. We'll see. Could we have acted 3 weeks earlier? Yeah, I guess. It's an interesting quote. It says, you always feel like you're overreacting before the pandemic hits. But then after the pandemic hits, you look back and say, why didn't I do more? And it always feels like we're doing too much, but trust me, we probably aren't doing enough even with the important moves that we've made. I'm having trouble understanding why a number of people in the general public are missing this point. When you see it laid out like this, you get it immediately, I'm sure. And to me, it's so crystal clear that I can't imagine somebody not doing it. And then you hear the argument, well, I've heard this a lot in the last week, the cost, that is the cost of shutting things down, is not worth the cases prevented. And I'm scratching my head and going, well, wait a minute. What if you don't do that? How is it better to have the health system overwhelmed and hospital systems disintegrating and people dying unnecessarily versus if we had done something? What is the economic cost of that? Not to mention the fear, the true fear, once people see friends and neighbors getting sick and dying in large numbers. I can't imagine what that would be like. I don't want to know. So we have the data right in front of us. We don't need to be, doesn't require being clairvoyant. What it requires is being smart. The best analogy that I have for this is that we've been invaded, our country has been invaded by a virus. Our world has been invaded by a virus. And it's up to us to respond. And I think back to Great Britain, London, in the 1940s when the German Luftwaffe was blitzing London, bombing frequently. And people had to hunker down at home, and they changed their entire behavior because they were at war. And they made sacrifices that ultimately saved their country and saved a lot of people living in London. We're in that situation now. And history will look back and ask us, how do we respond? So far in Birmingham, I think we're doing pretty darn well. But you can't just start and abandon the course. You can't just in the middle of the blitzkrieg decide, okay, well, I guess I'm tired of this. I'm going to move on and we'll just see what happens. That doesn't cut it. We have to stay the course because the data are so compelling and so obvious of what happens if we do nothing. Next slide. Go back to that one. Thank you. That's a picture from Italy. That's a nurse who passed out, exhausted, not just from the work she's doing, but the emotional toll. I think this picture is award-winning because it says everything. Next slide. So, what's our urgent problem now? Personal protective equipment. UAE Atlas trial, we're projected to run out of certain things in just a matter of a week or so, too. It's not looking good. There's been a plea to the federal government to help us. We're getting in line behind New York, which our problems seem relatively small compared to them. But yet, we have mechanisms through FEMA, through a disaster preparedness from the times when we were thinking about pandemics. There are equipment, there are things that are stored, there are ways that we can work to get the needed equipment to people. We need to have an organized response. And the governors and the state officials and the city officials are doing what they can. We need to have a clear partnership with the folks in DC, and it needs to be coordinated, and it needs to be effective. Now, we're at war. This is not something we can play politics with. This is not something that we can finesse and hope it just gets better. How can we put our healthcare workers on the front line to potentially pick up an infection like this? And you've heard my story. I'm 64. I'm not a spring chicken, but this thing has really kicked my butt. This is hard. And I think if I had underlying conditions, I might well be in the hospital right now. We can't put our healthcare workers in harm's way like that, expect them to do what we need them to do, and not give them the equipment. That's like sending a soldier into war without ammunition or without protective equipment for them. Can't do it. So we as leaders in our community, the Rotary, Rotoract, we have to galvanize and take this on and help our hospitals, help our health department, our civic leaders, our governor, to get an organized response that saves us from pending disaster. So, next slide. Sorry to bring this to you in such a hit over the head fashion. I don't know any other way to do it. This is bad. And people say, why is it different than the flu? Because it's new and because it's rampant and it's much more infectious, and we don't know the natural history once somebody gets it. We don't have any medicines for it right now. Maybe that'll be a game changer in a couple weeks if we end up with, maybe a couple months, we end up with regimens at work, boy, that'd change the game completely. But until then, let's be smart. Stay at home, only leave if it's essential. Essential. Stay at home otherwise. Nobody wants to get this. So I think I'll close there, President Philippe, and see what kind of questions we have. I certainly appreciate everybody bearing with me as I went through that.
Thank you, Mike. What a terrific presentation. We do have several questions. I'm getting texts and emails, so I'll just try to go one by one. Recently, there was an article in the New York Times and maybe even the Wall Street Journal discussing the fight against the virus. Is it actually worse than the disease? And we're talking about the economic impact. Any comments about that?
Yeah, I read the same things and I just shrugged my shoulders and said, what are they talking about? Because, yeah, there's going to be economic impact from this for sure. And I think that's why while Congress is acting right now, hopefully passing that bill to help give people relief. But what else can we do? If we do, I mean, ignore this? Just say, oh, well, let's let it run its course? That'd be unimaginably disastrous. The people who are writing that are not thinking in a global way about public health at all.
Right.
And I can't stand when I read stuff like that.
Another question we have is, how long does the virus stay alive? And I've seen many things. Apparently, it stays alive longer than we thought on surfaces and airborne.
Yeah.
So
It's hard. Yeah, in the air, aerosolized from somebody coughing, about an hour, it's estimated. So that's not really the main way it's transmitted, as you're alluding to. When it lands on a surface, say a handle at a grocery store or a cart, when you have the grocery cart, or worse, in a way, the gas pump. You know, we always pull the gas pump out, but that surface can harden for a week. So if you touch this thing, you get contaminated on your hand gets contaminated, and then you inadvertently touch your face, you potentially just inoculated yourself. It probably decreases in survival over time. So 1 or 2 days, it's going to be more infectious on the surface than say at day 7, but it can be detected up to day 7.
Okay. You may have touched on this, but how long should the shutdown and social distancing last? I guess we're talking once we flatten the curve. Yeah. And how, from your perspective?
My honest answer is I don't know. I think we have several things we want to watch. We want to see the bending of the curve, which I think we'll start to see in Birmingham doing everything we've been doing probably in about 3 weeks' time. I think we'll start to see that happening. I would guess that by 5-6 weeks, we should be where we want to be, assuming we keep staying the course. And then when to release, we don't know, because we haven't seen the evidence yet from China. It seems like when they release people back to the factories or to go to work, it seems like they're not seeing a resurgence. So whatever length of time they had is probably going to be what we use. And that might be at around 3 months. That's just a guess.
Okay. We have a question. If someone is young, early 50s, has a heart condition, actually this person had a bypass over a year ago, what is the increased level of risk? And what measures of self-isolation should higher risk people take? And how do you handle that with immediate family that has social distancing, but has still interacted with some family?
Right. Well, I think any underlying condition makes it harder to fight this thing off when it starts to relentlessly hit you like it's been doing to me over the last week. And especially if the lungs and the heart are not quite as strong as we want them to be or would like them to be, they can start to fail a little bit sooner. And that's why people are worried about that. So what can you do? Stay at home, like we just said. But when family comes by, I think as much as we want to hug our grandchildren or hug our kids, I think keep the distance. It'd be smart to just stay in isolation in that way. Certainly, if anybody's not feeling well, have them stay away. Do not have them come to the house. And otherwise, stay at home until this all passes. It was a very important thing.
I'm getting tons of texts with questions, so this is pretty good. When do you think the curve will flatten in Italy?
I heard today that it's starting to. And what's interesting, several cases were exported to Germany. Germany opened up their hospitals and allowed some of the overflow of Italian cases to be moved there, which is a really magnanimous thing that the German people have done. But I think the Italian curve is starting to bend now, but they've sure missed the boat initially, and it hurt in a big way.
Another question, will warm weather help slow this down?
Possibly. It's possible. I can give lots of theoretical reasons, but to be honest, it won't be till we experience warmer weather like that to see. The other SARS and MERS, when you look carefully at them, they do seem to have a seasonal distribution occurring more in the wintertime. The thing to be worried about, of course, is that if that's the case, will it come roaring back when the weather turns cool again? And we'll have to just wait and see.
Can we trust the Chinese health stats?
I'm not sure, but I think so. They've been publishing a lot in our literature, and the data that I've seen coming out of the papers have a lot of face validity. I think the courses of illness that I've seen described from there look accurate. I understand why we are skeptical, but I believe, I know actually the guy who runs their CDC in China, he's an admirable kind of upfront person, honest. And I think the data we're getting, at least from the Chinese CDC, accurate.
FDA recently approved, I forgot which company it was, to fast track or these new test kits that will give us an answer within 45 minutes. Have you heard anything about that? When they'll start shipping? Will they come to Birmingham?
Yeah.
I guess envision all of us getting tested at some point.
Well, maybe. One of the things I'd like to see, and I think it will happen, so I can't give you a timeline, but I hope in the next couple of weeks, with increased testing capacity, then the health department will be able to do all the right kind of epidemiologic studies that we're not able to do right now. For example, we've learned from the Diamond Princess story that a number of people who were isolated and pulled off the boat once they finally disembarked, they watched them and then they tested a lot of them. There were up to 17% of people that were on the boat who were definitely infected but had no symptoms. So what that means is that, yeah, they didn't get ill, but they were transmitting theoretically to others. And that's why it's so important to keep distance, because you can't really look at somebody and know if they might have a virus that you could pick up. So it's, we got to learn about that a little bit more in our country.
We've heard a lot recently about some drugs that are already out there, like the malaria drug and some others. Mixture has seemed to work. I mean, is that true, or is that part of social media? I mean, what's your thought on that?
Yeah, I think there are there